Madam, we are live now. Shall we start?
Yeah, start. Start.
So, good evening, doctor. Today, I, Shuman, on behalf of Shield Healthcare, welcoming you all in another interesting and important session on elimination of cervical cancer, preventable. And our guest speaker is Dr. S. Rajeswari, madam. Before start the session, let's have a look on our Shield Connect page, which is basically a knowledge sharing platform of Shield Healthcare. In that tab in the blog section, you will find different blogs, and that all the blogs are endorsed by many eminent doctors across India. And here, like this blog, it is endorsed by Dr. Muhammad Shama Sultana, madam. So, like that, all the blogs are endorsed by eminent doctors in India. And apart from that, these are the past webinars. Already, we have conducted in many topics and from the many eminent doctors. And this is the PCOS awareness blog. Here, you can find all the related talk on PCOS. And these are available in many regional language as well. You can see in the English, Tamil, Telugu, Kannada, Malayalam, and many more. And apart from that, we have many awareness blogs. In each and every awareness blog, there will be the related topics. And like this is the gestational diabetes mellitus tab. Here you can find all the related information on gestational diabetes. So apart from that, the most important thing is our key opinion leaders. So presently, more than 500 doctors are currently supporting us this knowledge sharing initiative of Shield Healthcare across India. So now it's time to start the session with Madam. And it's my honor to introduce Madam Dieter MBBS, DNBOG, and Madam is the consultant preventive oncologist, colposcopy specialist in Gleneagles Global Health City, Chennai. So with this short introduction, I request Madam to take over the session. And meanwhile, I request all the participants for your active participation. And please post your queries on the QA dashboard of the Shield Connect page. So once the talk will be over, we shall have a short discussion on this topic with Madam. So thank you very much, Madam, and over to you.
Good evening, everyone. Thanks for the kind introduction. Is it audible?
Yes, Madam.
Yeah.
Fine.
The topic I have chosen is elimination of cervical cancer, prevent the preventable. So, the one cancer which can be preventable, what is cervical cancer, which should be our priority now so that we can achieve it. The flow of the seminar is like this. Significant data I'll show, risk factors, HPV infection, about vaccine, screening and diagnosis, management of early lesions, WHO strategy for elimination of cervical cancer, and challenges. So according to Globocon 2020, cervical cancer comes at third position. First is breast and second is lip and oral cavity, and third comes the cervical cancer comprising 9.54%. Slides are changing, no?
Yes, Madam.
Yeah. In 2020, the total number of new cervical cancer is 1,23,907 cases, which comprises almost 18.3% of the new female cancers. First comes the breast, which is 1,78,361 patients. And in mortality, globally, every 2 minutes, one woman dies due to cervical cancer. But in India, when we take, it is also shocking, like every 7 minutes, one woman dies due to cervical cancer, which is very pathetic. The reason for this late diagnosis being lack of knowledge by the population about the symptoms, misconception of cancer and unawareness about the possibility of cure, lack of proper knowledge by the paramedical staff, lack of organized screening programs, lack of healthcare facilities and lack of funding. For all the cancer, we get patients only in third or fourth stage because of these various factors, poor awareness, poor economical factors in class of families. So we are getting patients in third and fourth stage only. The main risk factors for cervical cancer is almost 80 to 90% of cervical cancer is due to human papillomavirus, and then it is due to various factors like sexually active at young age, multiple sexual partners, early pregnancy, multiple pregnancy, smoking also causes. HIV patients have increased incidence of chance of getting cervical cancer, sexually transmitted diseases, low socioeconomic status, exposure to diethyl sylvester. Coming to HPV infection, which is almost comprises 90% cause for the cervical cancer, this HPV, human papillomavirus, is almost all sexually active person will acquire this human papillomavirus infection, but almost in 40 to 60% of the women it will be cleared in 2 to 3 years. First acquired soon after the sexual activity, and within 2 years when they get infected, it is usually transient. 90% almost will get cleared in 2 years. There are more than 100 types of human papillomavirus, and in which only 2 HPV types, 16 and 18, which comprises almost 70% cause for the cervical cancer. So as we have a cause for cervical cancer, it is easy for us to have a vaccine, many tests to screen and clear it at the earliest stage. Once infected, this woman, there is a chance of developing to invasive cancer is only almost 10% only. It will take nearly 15 to 30 years from the initial starting of the infection and progression to cervical cancer. In almost 65 to 30% of the women, it will regress or revert back to normal within 3 to 5 years, and only in less than 5 to 10% it will become cervical cancer. So cytology will detect the lesions from CN 1, 2, 3 at that stage, which are all precancerous stages. The other modes of detection being DNA detection, high-risk HPV DNA detection, which will detect at the early stage itself. So when we have a cause, we can easily prevent it. There are many ways of primary prevention. The most important being is the human papillomavirus vaccination. The other thing, girls and boys at appropriate age, they should get adequate health education regarding sex and condom promotion and male circumcision. The secondary prevention, women 30 years or older should have proper screening test with human papillomavirus test or other cytological tests. And the tertiary prevention being all women diagnosed with cancer should be treated adequately with surgery, radiotherapy, chemotherapy, and in last stage it is palliative therapy. So first we'll see about human papillomavirus vaccine. This human papillomavirus vaccine works best if administered prior to the exposure of human papillomavirus infection. So WHO recommends to vaccinate all the girls between 9 to 14 years of age, so which will have a huge response, and there is 80 to 90% reduction in these girls getting cervical cancer at their late stage. We have two brands of cervical cancer vaccine, human papilloma vaccine, Cervarix and Gardasil. Cervarix is bivalent and Gardasil is quadrivalent. Cervarix prevents infection from 16 and 18, and Gardasil, which is a quadrivalent, prevents infection from 6, 11, 16 and 18. These vaccines are given in 2 or 3 doses depending on the age, and from 9 to 14 years, 2 doses are enough, one at 6 months and that followed by 6 months to 6 months later second dose is given. For 15 to 45 years, 3 doses is given, 0, 1, 6. At the end of first month and at the end of 6 months, the second dose is given. So this is the primary prevention, and the other being sexual education and condom and circumcision. Coming to the 3 screening tests that we currently use are recommended by WHO and which we can use are visual inspection with acetic acid, conventional pap test and liquid-based cytology, human papillomavirus DNA testing for high-risk HPV types. This visual inspection with acetic acid is the cheapest method what we have and what we can utilize for mass screening programs, in which directly cervix is visualized and 3 to 5% of acetic acid is used to stain the cervix, and the abnormal cells will take up the acetic acid and become astrocyte. So those are the lesion areas from which we can tell it as infected or progress to CN1 or 2 like that, and if needed we can take the biopsy like that. The other being conventional pap smear, which needs adequate skills, in which the air spatula is used to scrape the cells from the cervix, then it is put on the slide. Then endocervical brush is used to take cells from endocervical canal, and it is also smeared on the slide. Both are fixed with fixative in the slide and sent to the cytologist. Cytologist will report whether any infection is there, whether it is a precancerous stage is there, and according to the report we have to manage. Then comes the liquid-based cytology, which is higher than conventional method, in which the spatula is rotated with the endocervical and ectocervix at the same time, and it is broken and placed in the fixative container, which is alcohol-based fixative, and sent to the lab, in which the cells are separated from the fixative. Cytologists read, and we have to see for any high-risk type of HPV DNA types or anything is there, so they report accordingly. Then comes the human papilloma virus high risk HPV DNA testing, in which similar container is given, and the cytologist will see whether any high risk or low risk human papilloma virus is there or not. COVID has taught many things, in which from research to reality, which may come the self-collection human papilloma virus kit, in which the self-collection kit is given to the female, in which she will collect the smear in a suitable position by inserting the spatula into the vagina, and take the cells and put it in the fixative and send to the lab. So it is privacy is maintained. There are many brands coming up, and this is will go from research to reality, and it may be in practice also, become to practice. The cytology is reported in by Bethesda method of system, in which the interpretation of epithelial abnormalities, squamous cell, any abnormality is there if it is atypical squamous cell of undetermined significance, atypical or a precancerous invasion like cervical epithelial lesion 1, 2 or 3. The 1 means low grade, 2 and 3 will become high grade, or any cancer is detected also it can show, or any glandular cell abnormality is there. If it is there, atypical cells, endocervical cells is there, they will report accordingly. So interpretation of other abnormalities, if any endometrial cells in women more than 45 years, postmenopausal women, it should also be checked in the Bethesda. So if any abnormal factor is reported, then the patient will be triaged to colposcopy to see whether any abnormal area is there, and biopsy will be taken from that, in which the cervix is magnified and visualized through the colposcope, and 3 to 5% acetic acid is used to stain the cervix. The abnormal cells will take up the acetic acid and become astrocyte. Then Lugal iodine is used. Then the astrocyte will become more prominent, and from the area the biopsy is taken. This is a patient who had intermenstrual spotting, and she came for a pap smear. It showed abnormality like saying 1. She was posted for colposcopy, in which she had a circumareolar astrocyte area, and on Lugal's iodine it became more prominent. From the astrocyte areas we took biopsy, and she was diagnosed as grade 2 intraepithelial lesion. So once precancerous lesions are detected, there are many methods of detecting, treating them with cryotherapy, thermoablation, loop electrosurgical excision procedure, large loop excision of transformation zone, and cone biopsy. The cryotherapy, in which the liquid nitrogen is used mostly, and the cervix is cryo done with freeze. The cells are freezed, and a good cryo is obtained by freeze-thaw freeze technique. Then comes the thermoablation, in which the heat is utilized to coagulate the cells, and the cells, abnormal cells will be coagulated. Then leap in which loop electrosurgical excision, in which the abnormal areas once stained will be electrocoagulated and it will be removed with a thin rim of electric wire. For these things, no anesthesia is required. In large loop, due to pain, anesthesia can be used, general anesthesia. For cold biopsy, patient needs general anesthesia. So once we have these methods of primary prevention and secondary prevention, so in what resource settings what can be used? In a good resource setting, human papillomavirus setting, primarily HPV testing along with cytology can be utilized. In limited resource setting, only visual inspection with acetic acid can be utilized. The target group in good resource setting might be 25 to, it should be started at 25 years of age and it should be continued till 65 years of age. Whereas in limited resource, it should be started at 30 years and it should be continued till 65 years. The age to start is a good resource setting. It should be 25 years once married. After that, she can start from 25 years. Once in 5 years, if HPV is done. With cytology, it should be once in 3 years. Visual inspection with acetic acid is at 30 years started, and every 5 years, at least once once or twice or thrice in a lifetime, if we test, it is more important. Utilized. So coming to when we have to stop the screening procedure. In a good resource setting, if the age is 65 years with consistent negative results in last 15 years, she can stop the screening procedure. So women with no prior screening till 65 years, she should have one smear to see whether it is negative and then it should be stopped. So in follow-up method of the treatment interval, if she had any treatment for abnormality, the HPV or cytology should be tested 1 year later to see it is reverted. In VA, if through VA also, if any abnormality is detected, it should be checked with VAA 1 year later. Screening following abnormal reports more than CN2, irrespective of method of treatment, the woman should undergo screening for 20 years. Follow-up should be done for 20 years. Whereas in women who has undergone hysterectomy for any abnormality in the cervix, she should follow a proper screening procedure till 20 years. If she has undergone hysterectomy and no record is available, please confirm by examination whether cervix is there or not and go through the records whether she has any biopsy report or histopathological examination of the final uterus showing any cervical lesion, and then stop the screening procedure. If she is in doubt or you are in doubt, please have a wall smear done so that it shows anything abnormal, you can follow her. If it is normal, you can stop the screening to her. So these screening tests should be done for normal women. But when a woman comes with abnormality or shows any signs and symptoms of cervical cancer like continuous vaginal discharge, in spite of treatment, recurrent vaginal discharge, foul smelling, thick discharge, repeated vaginitis and UTI, postcoital bleeding, non-healing or recurrent cervical erosion, irregular or intermenstrual bleeding, especially in premenopausal phase, these women should be immediately tested or to be gone to colposcopy or other diagnostic procedure should be done immediately for these women with signs and symptoms. So, as we have a proper vaccine and many screening methods to eliminate cervical cancer, WHO has called for the strategy of elimination of cervical cancer. This call for action for all countries, which targets incidence rate of below 4 per 1 lakh women. And WHO tells that it should happen within the lifetime of today's young girls, and for which it has framed the 3 pillars: HPV vaccination, screening and early treatment of precancerous lesion, prompt referral, and palliative care for necessary patients. These 3 pillars target is 90% of girls should be fully vaccinated with HPV vaccine by age of 15 years by 2030, and 70% of women with the age group of 35 and 45 should be screened with these preliminary procedures, and 90% of women diagnosed with any cervical cancer or any cervical malignancy should be getting proper treatment. So it framed on November 17, 2020, it launched this global strategy to eliminate cervical cancer with a resolution passed by 194 countries to preserve these girls, and the world important monuments glowed teal, and WHO assistant recently told that it is many decades of neglect which has caused the death of many women. Now we have many challenges in eliminating cervical cancer. The major thing being lack of proper planning at all levels, cost of HPV vaccine, vaccine hesitancy, vaccine misinformation, and poor awareness. Added to these challenges, this COVID-19 pandemic has hampered the cancer screening with many large panic and economic breakdown, and due to repeated lockdowns, many patients could not come for screening, even symptoms are detected, and no screening programs has been done for the past 2 years by many hospitals. Almost 100% the screening program for all the cancer has been stopped in many places, and normal protocols totally is affected in all by means of this COVID pandemic. So we have lost many patients in screening. So we have to catch up the missed screening cases. This is the high time, and it is the need of the hour to catch up these missed screening cases, and hence we have to do many awareness programs. As I see, most of them are aware. So the awareness program should be taken to the next level, which is the action plans. A proper planning and execution of these awareness programs and the screening programs will make us achieve the target at all levels. So proper camps should be conducted, opportunistic screening should be done, and it should be done in a mega level to have to achieve this plan. So I'll conclude with the study which showed that a Malaysian study for a study on cervical cancer awareness, in which there is lack of a group of people were studied to know the awareness of pap smear. There is total lack of recommendation of healthcare providers was the main key point got from them, and they have boldly told, like they straight away told the doctor did not advise them regarding pap smear. And once if they are advised regarding it, they would have done. So it's a major drawback from the healthcare side. So it should be properly dealt. So all the healthcare workers at all levels should educate the patient regarding the pap smear and other screening modalities what we have to make them do the pap smear or any screening test and get eliminated from the cervical cancer. So the main take-home messages being cervical cancer is a preventable cancer. Action should be taken at all levels. So increase the awareness. Screening activities should be improved. Vaccination coverage should be improved. So from COVID vaccination we have learned the lesson. Data are preserved, and data we could get through various means, and from public side for what vaccine hesitancy is there we know. So we have to get the patient proper education regarding the vaccine, everything we have learned from this COVID. So regarding the HPV vaccine, we have to get these lessons and utilize in proper way. The cost will come down once it is used in mass. So we have to make the public use it in mass programs so that the cost will come down and many will get benefited. So early detected lesion should be properly managed, and so with this, vaccination and early detection are the key factors for eliminating cervical cancer. So let's all join hands to make it happen. And any suggestions, please mail it to me. And we have to join hands to eliminate cervical cancer. Thank you.
Thank you very much, madam, for this nice presentation. Just give me 1 minute time to check if any question is there.
Yeah.
Madam, one question is, as you mentioned that HPV, human papilloma virus, is the most common organism for this cervical cancer, but as it is almost related to this sexually transmitted infection also. So in terms of this cervical cancer, does it can occur in case of some who are some multiple sex partner or something, or it can happen another in a normal way also?
I can't get that. In multiple sexual partners, they have
Yes,
high
yes.
risk of getting cervical cancer.
Yes, so a normal person is also can get this kind
Yeah,
of
yeah. Normal.
that's
Actually, the human papilloma virus, the infection will be almost every sexually active woman will have initially. So in 1 to 2 years, like 3 to 5 years, it will get cleared off. Our immunity will get clear it off. So most of them will become normal. When they have multiple sexual partners, they'll have repeated infection and many chance of getting high risk human papillomavirus. So they have the high risk of developing cervical cancer.
okay, ma'am. Then how long does it take for this HPV to cause abnormal cells in case of these cervical cancers?
Like from infection to cancer, it will be like 15 to 20 years. 15 to 20 years. Like once at 25 years, if she is getting infected, it will become cancer at the age of 35 to 40 years. So we have a long gap in which it will start from say in one, like I have this slide. Yeah. So infection to cancer, it will almost come to 30 years they have put. So this in the 30 years, it will come from infection to say one, then two, then three. These three things are pre-cancerous stage. These are not cancer. These are pre-cancerous, before cancer stages. In which when we give this treatment like cryotherapy, thermoablation, it is 100% effective on these to cancer stage itself, and they can preserve their uterus, and they will be totally normal, and they can have a normal life with proper screening once in 5 years, because they have high chance of reverting. So they will be under good follow-up, and most of them will not go to cancer stage itself. Minimum 15 years you can take, like 25 years means at 40 years only she will have that diagnosis of cancer. In between she will have say 1, 2, 3. It will have a progressive phase.
Yes, madam. So that means it is very difficult to means, identify in the first stage whether the woman has this kind of infection or
No.
not.
Yeah, this is what I'm telling is it is not like it will produce symptoms at say in 1, 2, 3. Even in cancer also, every woman will not produce symptoms. Only some will have symptom and go to doctor. Hence, the screening test, any screening test is meant for a normal healthy population. It's like mammogram, any screening test, it is not for diseased population. It is for normal healthy women population. We are asking them to undergo pap smear or this BAA at least once in their lifetime, or twice or thrice. Even once in their lifetime will save them if it is at say 2 or 1. If detected at that stage, they can be reverted totally normal without becoming to cancer. Hence, any screening test is for normal people. It's not for diseased women. Diseased, once symptoms starts, it is the disease, so they should be going for diagnostic test only.
Thank you, thank you very much, ma'am, for this nice deliberation. And ma'am, just last question. So, do you recommend this vaccine for all?
Yeah, this vaccine, like its cost is like I can't tell, like it will be like should be given like COVID, how we took, how they took. Everybody standing in queue, and we are forced to, we are immediately we took. So from this we have to take the lesson, and this HPV vaccine should be given for all girls. If we give the target girls like 9 to 14 years now, like when they become 35 years to 40 years, we have to see, wait for 20 years to see the effect. So we have to give for all the girls from 9 to 14 years, then 15, above 15 years, it is 3 doses. If we target that 9 to 14 years, it will be like a pediatric immunization, like what we are getting hepatitis 1, 2, 3. Like other vaccine, it will be there. In pediatric immunization card, this human papilloma virus vaccine will be termed as optional vaccine. Like typhoid, chickenpox are optional vaccine. This will be termed as optional vaccine. But it is in the IAP card, immunization of Association of Pediatrics card. So every girl should take, and in Australia, the boys also getting vaccinated. It's not only for girls. Even if boys are getting, it will be like protection for many anal, oral, like it will cover most of the cancers caused due to human papillomavirus, the other cancers being anal cancer, oral cancer. So it's a broad topic and it should be given for all. And after marriage also, till 40 years it can be given now. Till 40 years also we can give. It will have protection mildly. But even after taking this vaccine, they should go for proper screening. Like pap smear should be done for once in 5 years, because the other is they can get for adenocarcinoma. For those things it will not give protection. 90% it will give protection. So after vaccination also, all the women should go for screening.
Thank you very much, ma'am, for this nice deliberation. So, ma'am, I could not find any other question. So, if you allow me, then we can conclude this session.
Yeah, it's like one of the cancer which we can prevent and totally eliminate. It's not like eradicate. Elimination.
Yes.
They are given a target, and it's not only a job of particular group of people. Everybody should be included in this presentation blogs. Everything should educate from all levels, from pediatrics, all the school. From school, we have to get the parents, teachers educated, so that this vaccination should reach, and other group of people should get screened. If both things are happening, definitely we can show some improvement. Like New Zealand, Australia, some countries are near target. Like they will, in 10 to 15 years, they will be in the target. They'll almost eliminate cervical cancer. But we are far ahead. We are far ahead. Like we have to wait for 50 to 70 years, but even then this effect will not be enough, and we have to put more effect for eliminating cervical cancer, like a mass screening program, mass vaccination program. Like actually from COVID, I have got many lessons, like how to make vaccination more effective and how to educate people regarding vaccines. So let's see what happens, and we have to work out for it.
Sure, madam. Thank you very much, madam, for this nice presentation and such a nice discussion as well. So in future also, we will look forward for some valuable session with you, ma'am. So thank you very much once again for your valuable time in our platform, Shield Connect. Thank you. Have a good day, ma'am.
Thank you, ma'am. Thank you, ma'am.
Thank you.